Okay, thank you so much. So I'm actually really thrilled to introduce Dr. Bedimo, but also really amazed that he's going to now give us a talk on what did I miss, which is actually kind of a hard thing to do because this is, right now the EAS, the European AIDS Conference just finished, and there's a lot to go through. So Dr. Bedimo is the chief of the infectious disease section at the VA North Texas Healthcare System and a professor of medicine at UT Southwestern Medical Center. He has been really deeply involved in both laboratory-based and translational and clinical research in his work. Over the years is a longstanding ACTG investigator, works a lot on non-AIDS defining illnesses, hyperlipidemia, adherence to medications, alcohol treatment, just a very varied clinical research-based career, and has served on the leadership of ACT, HIV, and other organizations. And we're really thrilled to have him here to say, in case you missed it. Thank you.
Thank you so much, Dr. Gandhi, for such a kind introduction. And it's an honor to be introduced by esteemed colleagues and friends like Dr. Gandhi, the West Coast variety, and it's not the East Coast variety, Dr. Raj Gandhi. So in case you missed it, I would like to just go through over a few studies that might not have been covered by the previous speakers. But of course, this is no way going to be exhaustive review of the recent meetings and the recent presentations. But what I'd like to do is to show a few studies that just might impact your practice, if not now, in the near future. And here are my disclosures, research funding for ViiV and certificate has been bought for ViiV, Merck, Gilead, and Teratech. So here's a brief outline. We'll touch on a couple of studies that may have been covered a little bit earlier, and in strategies for prevention, moving gradually away from once daily oral ART for prevention, and strategies for antiretroviral naive people who are living with HIV, where are unmet needs. Not a lot of data on the newer agents during pregnancy, and there is some new study that may really do a lot in bridging that gap. Strategies for treatment experienced people living with HIV, and a lot of our data is coming from resource-limited settings, as this population is dwindling here, less than 1% of people in your practice, but probably 50% of your headache. So we will look at some of the data that is using the NADIA study. Metabolic complications with HIV, weight change is a clear and present danger in HIV, and we will look at some nuanced data on that. Then COVID prevention and treatment in HIV. Do people with HIV actually respond to vaccine? And then also new oral options for sterilized people with COVID-19. And then we'll end with cancer prevention in people with HIV. So I will start many of these by unmet needs, and what potentially the data I will present will address as a gap. And here is the data on HIV prevention, a great slide by Ralph Landowitz at AIDS 2020, showing you efficacy of oral options for PrEP. What you will see, a cursory view of this graph is you will see the unmet needs. Poor response by and large in females, and even not so great response in the pivoting ring in females. So a lot of possible explanations. These poor responses in many of the PrEP studies, females have been ascribed to poor adherence, but there could be some biological reasons. So here comes PrEP that is not oral. PrEP with cabotegravir versus TDF-FTC, phase 2-3 randomized controlled trial in HIV PrEP in international study. High-risk MSM and transgender women started with oral lead-in of 5 weeks of cabotegravir and then moved to every 2-month injections compared to oral TDF-FTC. Stopped early for this reason. There is a 13 8 new HIV infections in cabotegravir, 39 in FTC TDF, which translates into a significant 0.34 hazard ratio favoring cabotegravir. And so safety is here, a lot of injection site reactions, but the great majority of them being mild. And so cabotegravir was non-inferior and indeed superior to TDF-FTC. And on the heels of this, another population that has been poorly studied in many of the PrEP studies is the cisgender women. And this is a phase 2/3 randomized double-blind placebo-controlled trial of HIV, active control HIV PrEP international study in highly cisgender women. It's same construct after a lead-in of 5 weeks. Cabotegravir was administered Q2-month injections compared to TDF-FTC orally, and you will see here very similar. Women in the cabotegravir group had 89% lower risk of HIV infection compared to TDF-FTC. And so that amount to 4 infections in cabotegravir and 36 in TDF-FTC for a hazard ratio of 0.11. And also safety is similarly to the other study, cabotegravir being found non-inferior and superior to TDF-FTC for PrEP. Now, can we do even simpler? And this is an oral PrEP that could be administered every month. Population PK simulation of islatravir triphosphate, which is predicted to be protective at that threshold of 0.05 picomole per million ppmcs, and mostly oral islatravir at 60 milligrams was selected for phase 3 HIV prevention study because it's predicted to exceed the PK threshold within a couple of hours of the first administration and stay on that throughout. So very exciting possible new options. Not only is it still oral, but it's oral every month, not every day. But another potential formulation for islatravir is as an implant. This is a double-blind placebo-controlled trial in a low-risk population, 3 different dosing, 48 milligrams, 52 milligrams, and 56 milligrams subdermal placement in the upper arm, and there was removed after 12 weeks, and they followed up 8 weeks after removal. This is plasma and PBMC PK, EKGs, vital signs, and safety were collected. And it was found, as you can see on the panel on the right, that the 56 milligram implant were projected to lead to concentrations above the thresholds for over 52 weeks. So this could be a monthly administration. Now, if we go back to saying, well, okay, so what are the unmet needs still in HIV prevention? Maybe ultra-long-acting options like islatravir implant, but that could be removal in case something goes wrong. So we've seen Atlas and FLAIR that shows that oral options, subcutaneous intramuscular injections of cabotegravir ribavirin were good. And then we've seen the cabotegravir for PrEP. So maybe other options would be found for treatment and prevention, but that would allow you to remove the administration of the depot formulation in case something goes wrong. This is a very exciting, not yet ready for prime time in situ forming implant where you inject dolutegravir, it solidifies, but you can easily remove it later, and it has potentials for both treatment and PrEP. Now, unmet needs for treatment experienced people on current with current antiretroviral options. Dr. Gandhi has presented to you options for heavily treatment experienced with newer agents, islatravir, lenacapavir, and so on and so forth. But we're talking about early failures. After failure of NNITI-based therapy, again, a lot of studies from Africa, mostly second line and earnest, so suggesting that ratiregravir plus 2 NITI was non-inferior to lopinavir, ritonavir plus 2 NITI, and ratiregravir plus 2 NITI was non-inferior to ratiregravir plus PIs. Now, the remaining question INSTI-based ART in treatment experience. Are there data with contemporary INSTI and the second line, contemporary PRs and the second line INSTIs, dolutegravir and bictegravir. So here comes the NADIA study, which was just published a couple of months ago in the New England Journal of Medicine. So this is a contemporary PI, option darunavir, ritonavir, compared to dolutegravir, each with TDF, FTC, or AZT, 3TC, 464 participants failing first-line NNRTI-based therapy. Now, at baseline, 50% of them had K65R and 86% of them had M184V. So these were people who already had a significant resistance mutations. So there was excellent virologic response at week 48, 90.2% for the dolutegravir and 91.7% in the darunavir, ritonavir. But what I think is more important to note is that the option was equally effective at all, at both viral load strata, less than 100,000 and more than 100,000, and CD4 strata less than 200 and more than 200. But with either 0, 1, 2 or more predicted active NRTIs in the regimen, that option worked. So after NNRTI therapy failure, dolutegravir or ratitegravir, ritonavir plus TDF-FTC or actually AZT-3C was efficacious regardless of the amount of NRTI resistance. So this is something that could be operable in your clinic in somebody who has failed an NNRTI-based regimen but had M184V, K183N, and maybe K65R. Can you reasonably put them on a newer integrase inhibitor with TDF-FTC or TAF-FTC? According to Nadia, you probably can. So, and the prompt administration of antiretroviral therapy to optimize maternal outcomes and preventing MTCT is important. However, there's no adequate data on safety and efficacy of newer integrase inhibitors and newer tenofovir formulations, tenofovir alafenamide, during pregnancy. So the impact 2010 vested trial is filling that gap. They looked at people 14 weeks or greater in pregnancy with no previous ART. They allowed up to 1 week of ART during pregnancy before enrollment, and they were placed randomized to dolutegravir plus TAF-FTC versus dolutegravir plus TDF-FTC versus efavirenz TDF-FTC. And this is the viral suppression at delivery favoring the combined dolutegravir containing groups, i.e. dolutegravir plus TAF-FTC plus dolutegravir plus TDF-FTC compared to efavirenz TDF-FTC. So that's number one. We all have been familiar with the fact that integrase-based regimen drop the viral load quicker. This is even more important in the context of pregnancy because the sooner you accomplish that, the better you likely to prevent maternal-to-child transmission. So first important outcome to impact 2010 vested. Second important outcome is that the composite adverse pregnancy outcome, which was the primary endpoint, by the way, spontaneous abortion, stillbirth, preterm delivery, or small for gestational age, favored dolutegravir, FTC, TAF over the two other groups. This is the first thing. The second thing is that the preterm deliveries were also fewer with dolutegravir, FTC, TAF compared to efavirenz TDF-FTC. So this is number one, the composite outcome favoring dolutegravir, FTC, TAF, and the preterm delivery at week, i.e. just at less than 37 weeks of gestation were favoring dolutegravir, FTC, TAF. So virologic endpoint, good. Safety also appear, for the mother and the child especially appear to be good. So we've all heard about weight gain. I think that it's something that have challenged us in our clinics to figure out whether it's indeed important to use the guidelines recommended first-line agents all people, including those are more likely to gain weight. We have figured out that people initiating antiretroviral therapy with regimens containing INSTIs or TAF are more likely to gain weight. They're also more likely to gain weight if they're females, if they're non-white. And so those are demographics that tell us that somebody is more likely to gain weight, but we don't know exactly the mechanism. Number two, if you already control the virus and you switch people to either INSTI-based regimen or TAF-based regimen, they're also likely to gain weight. And so that is important. What is important also to figure out is if you remove HIV from the equation, i.e. you give people either INSTIs or TAF when they don't have HIV at all, and compared to, of course, placebo, not another HIV regimen, you may probably be able to delineate the effect of the drug in a vacuum without HIV on board, without other antiretrovirals. And this is exactly what was done in this analysis of PrEP studies. First red box is looking at PrEP studies with TDF or TDF-FTC compared to placebo, showing that people who receive TDF-FTC have less weight gain than those on placebo. Second group of study, there was a trend towards less weight gain in people receiving TDF-FTC compared to cabotegravir in PrEP. And so the totality of the evidence in this particular data suggests that, yes, we have data showing that you're likely to gain a lot of weight on TAF and INSTIs, but probably TDF might lead to weight loss, not gain. Now, what about efavirenz? Probably the same thing. And this is a pooled analysis of 12 prospective clinical trials switched in biologically suppressed people versus remaining of baseline regimen. The greatest risk was from the switch to from efavirenz to rilpivirine or abacavir cobicistat and switch from TDF to TAF. But it's now becoming likely that exposure to TDF or efavirenz might actually suppress a weight gain that would have occurred of antiretroviral therapy. So important nuance in the weight change dialogue. Now, other unmet needs for COVID-19 prevention. Now, the CDC has recommended that moderately to severely immunocompromised people receive an additional third dose of COVID. And these are the categories: receiving active treatment for cancer, organ transplantation, hematopoietic stem cell transplantation, and moderate to severe primary immunodeficiency like DiGeorge syndrome, as well as quote unquote advanced or untreated HIV or high dose corticosteroids. On the right, you see data from CLL. Yes, indeed, antibody response was weak in those. And this is a very helpful diagram from the ACIP. They looked at a number of studies with cancer in blue, with hemodialysis in green, with organ transplantation in yellow, and immunosuppressive therapies. And just looking at the percent with antibody response, the cancer, organ transplant, immunosuppressive therapy were all associated with lower immune response. However, no good data on antibody response in people with HIV, despite their inclusion in those guidelines. But now data occurs. So do people living with HIV respond well to COVID-19 vaccines? This is a cohort of 143 people living with HIV, age 18 or above, and they use a control of 261 immunocompetent healthcare workers. Antibody response was measured 26 days after administration of the Pfizer vaccine. And all the people living with HIV were virologically suppressed, and they had a quite robust CD4 count of 700 with confidence interval from 648 to 747. So these were biologically suppressed with a really good CD4 count. And the conclusion, as you can see in the graph on the right, in the RBD binding IgG or log 50% neutralizing titers were equivalent between people living with HIV and control without HIV. The conclusion is that this vaccine was immunogenic as safe in people with HIV on ART with suppressed CD4 count and on unsuppressed CD4 and suppressed viral load. Those are the words. So same question, do people living with HIV respond well to COVID-19 vaccine? Now we're looking at a cohort of 100 people living with HIV, median CD4 count of 500, only 5% of whom are viremic, and 100% without HIV will receive the same mRNA vaccines, Pfizer for 75% of them and Moderna 25% of them. The predictors of poor response here were low CD4 count, unsuppressed viremia, and receiving the Pfizer versus Moderna vaccine in this particular analysis. So each 100 CD4 cell increase resulted in 28% geometric median range of higher IgG and 26% higher viral neutralization titers. So this is very consistent with the previous study where most people had very high CD4 count and they all respond just as well. This one suggesting that as you lower the CD4 count, you probably do not respond as well to COVID-19 vaccines, at least the mRNA. There's other studies that have been done looking at AstraZeneca vaccines, but that's also showing similar response, but mostly in high CD4 count people. Now, what are the unmet needs in the outpatient management of COVID-19? So we had monoclonal antibodies that had shown 70 to 80% decrease in hospitalization or death in outpatient COVID-19 people. So that's why the DHHS guidelines has this recommendation that's in the box here that anti-SARS-CoV monoclonal antibody protocols are recommended for outpatients with mild moderate COVID-19, and those are the regimen recommended. Now, what are the unmet needs? No oral options. Until molnupiravir that Dr. Gandhi presented earlier, which is an oral drug that had about 48% decrease in hospitalization and death. So very promising results. And then just yesterday, a press release, and I would never have thought that I would be presenting press releases in the CME program, but this is the COVID era. We're doing things out of the box. So that suggests in this study called Evaluation of Protease Inhibition for COVID-19 in high-risk patients, so EPIC-HR. This is a protease inhibitor that is boosted by ritonavir. This is orally bioavailable and SARS-CoV protease inhibitor, which has pan-human coronavirus activity. You see at the bottom right that it works just as well in SARS-CoV-1, MERS, and 229E. Excellent off-target activity, oral activity in mouse-adapted SARS-CoV-2 model, and this is what it looks like. An interim analysis that was the subject of the press release yesterday was 89% reduction in COVID-19 related hospitalization and death from any cause through day 28. If they was administered within 3 days of admission. But the study that people administered the drug within 5 days of symptom onset. So this is quite promising, and enrollment was stopped, recommendation by DSMB, and then they have submitted the data to the FDA, and probably gonna have an EUA later. This is a very nice a table I lifted from Eric Topol Twitter page, comparing now the molnupiravir Dr. Gandhi presented to you earlier to this Pfizer molecule. And efficacy, you see here that if the data holds, it's incredibly great efficacy with no death within 5 days, but has to be boosted with ritonavir. And this is specifically designed for COVID and is a protease inhibitor. And we will see how well it's priced. So we will conclude now with yet another press release. And this is 2 in a row, but I think this is very exciting data and I cannot wait. I was told yesterday it will be in the diseases of the colon and rectum, probably in the next week or 2. This is a long time coming, also called ANCHOR trial. 4,446 people living with HIV with high-grade squamous intraepithelial lesions were randomized to treatment versus active monitoring. And the treatment was either ablative therapy, HRA guided. That's what most patients got. But some got topical treatment with mucomod, fluorouracil, or trichloroacetic acid. and this was 21 clinical sites around the US. The treatment arm, they were, if they had recurrent high-grade lesions, they were retreated, while the active monitoring arm were watched again. And so all participants received HRA Q6 months, and rates of anal squamous cell cancer were compared. And again, in red, this is the quote from the press release from, I don't know, so yesterday, a couple of days ago. Chances of progression to anal cancer were significantly reduced. Now, I cannot even tell you by how much. So exciting new data, and I think that we have gotten accustomed to things being rushed in the press before peer or preprint, before peer-reviewed publications, but this is where we are. So I really would like to thank Dr. Raj Gandhi and Dr. Tim Gulick and Dr. Paul Sachs for contributions. I think I can entertain questions. Thank you.
Thank you so much, Dr. Bedimo. And let me just see if, please feel free to put any questions in the chat. You went over great and really important studies and very new developments. And I think the anchor study especially is really going to change our clinical management, and we now have a protease inhibitor for COVID. Everything is looking up. And maybe we'll have molnupiravir with a protease inhibitor someday.
I sense combination studies coming.
Yes, it's just like
it's just all over again.
It's just like those good old days with HIV. That's so right. It's very exciting. I mean, I think a lot of people. Well, I'm waiting for questions. I'll, ask a question I'm often, asked, which is that, do you think the mutation potential of a nucleoside analog, does that worry you with molnupiravir? You think it's short enough that we're not worried?
Yeah, so it's been a question that people have asked, and there are a couple of assays that I'm hearing Merck has conducted. One of them was this in vitro study, I think it was on as blue, something like that. That those studies are mutagenesis studies that can tell you if there is a signal for mammalian cells mutations. Of course, has been incredibly important question that I hope it's not the case, and I'm hearing from Merck that this is not the case, that some of the studies that they have conducted have not suggested that to be, but hopefully we'll see that in print.
Okay, well, I'm going to turn it over to Chip because I know that you're monitoring this next part. And so that was a great talk. Thank you so much.
Thank you very much.